This podcast is not meant to be professional advice of any kind. It is meant to be informative and entertaining. If you make any changes to your life, see the appropriate professional before you do so. What kind of SuperAger are you? Go to ageist.com/quiz. Take the SuperAger quiz, and we'll send you directed, personalized information to help you SuperAge the best that you can. Welcome to SuperAge. My name's David Stewart. I am the founder of Ageist and your host on the SuperAge show. We talk about how to live healthier, how to live longer, and how to be happier. And who doesn't want that? Today's show is also brought to you by Ned's Mellow Magnesium, designed to help busy people sleep better. Go to helloned.com/ageist and save 15%. Get yourself some better sleep. Today's show is also brought to you by Timeline Nutrition, with their breakthrough product, MitoPure, the first clinically tested urolithin A supplement, which is showing tremendous results for mitochondrial health. Go to timelinenutrition.com/ageist, use the code ageist at checkout, and save 10% off your first order of MitoPure. Today's show is brought to you by Inside Tracker, the dashboard to your inner health. Go to insidetracker.com/ageist, save 20% on all their products. Welcome to episode 155 of the SuperAge podcast. This is going to be dropping on October the 11th, 2023. This week on the show, we're going to talk about pain. And we've got Afton Hasset, who's a pain researcher at the University of Michigan. She teaches in the Department of Anesthesiology there. And we're going to find out what chronic pain is, how the brain actually processes pain, how we sense pain, and what to do about chronic pain, which is a huge problem out there. So very much looking forward to that conversation with Afton. And speaking of pain, not the chronic variety, but just the temporal variety. 2 days ago, I had my COVID booster, and I got it at the same time I got a flu shot. And the reason I got the COVID booster, I love vaccines, by the way. They're anti-vaxxers. I'm a maxi-vaxxer. I love vaccines. I think they're amazing things. And because I don't have a spleen, I'm highly vaccinated against all kinds of things, and that seems to work out for me. But a good friend of mine came down with COVID last week, and when I heard that, I was like, oh, right, I got to get the booster. So on Saturday, I went and I got the booster with the flu shot because, whatever, let's get this over with. But then, Saturday night, I had sort of baby COVID and baby flu, and I thought everything would be fine by today. But so it was like 2 days ago, I got the shots, and last night, my sleep was still kind of a mess, and Saturday night, an all-time low HRV reading, heart rate variability, which means my body was under a lot of stress. And then I thought, this morning will be fine. And I checked it, and it was like basically the same. So hopefully tomorrow. I feel okay, but a little not quite mentis competus. I don't know if it was like the lack of sleep or... Anyway, I encourage everybody to get vaccines. I'm pretty strong opinions on these things. And I think if there's a proven vaccine out there for something, you should get it. And it was explained to me by Mike Roizen. I was talking to Mike about vaccines, and I said, well, what's why do we want to get the flu shot? And he's like, the flu actually kills a lot of people, but it probably won't kill you. What it'll do, though, is it's going to cause this like massive inflammatory response in your body. And that's what's going to cause sort of longer term problems as associated with aging. So that's according to Mike Roizen from the Cleveland Clinic. And people have been asking, how's my recovery coming from knee surgery? Really kind of awesome. And on that topic, what I'll be doing is putting together a comprehensive article on Ageist about all the protocols that were recommended to me and what I think may or may not be working. And I think we may do a podcast on that soon too, with sort of all the things that I did. One of the things I did notice is I wear an Apple Watch, and it sort of has something close to a VO2 max reading. And VO2 max is how much oxygen can you utilize at a time. It's a reasonable indication for like how fast you can run or, things like that. So I'm 64, and back in May, my VO2 max was about 44, which was pretty good, not great. I mean, I like it around 50. But then I couldn't really do high intensity exercise because it hurt my knee. And then I was preparing for surgery. And so it went down to I think 31. But since I've been training again, it's back up to 36. And hopefully will continue to improve. What's interesting about these sort of metrics is seeing how they change over time and how relatively low amounts of inactivity will have one sort of an impact and then more higher activity. And I just want to touch on that for a second. I've got this PT who thinks he's this is not physical therapy. This is like, I don't know, Olympic ski training. I have not been worked this hard in really 25 years. So that's having quite an effect on things like my sleep. So in general, if you look at, I wear a Whoop at night, my sleep previous to this, I was averaging somewhere between 7 hours and 45 minutes a month and 8 hours. But right after I had surgery and recovering from that, and then all this like intense training, my average is 8 hours and 30 minutes. And some nights I sleep, oh my God, like 9 hours and 45 minutes. Anyway, getting stronger. So for all of you out there who want to know, surgery recovery, doing really well, stronger than ever. We're going to get with Afton Hasset in just a moment and talk about her book, Chronic Pain Reset. And we're going to dive into the world of pain after a quick word from the sponsors of this show. The first sponsor of today's show is Timeline Nutrition with their breakthrough product, MitoPure. We all know how important mitochondrial energy is, and especially maintaining muscle and strength as we age. Urolithin A, which is found in MitoPure, has been clinically proven to increase muscle strength and endurance with no other changes in lifestyle. Urolithin A is essentially upgrading your body's cellular power grid, giving your body the energy it needs to optimize. I've been using MitoPure for a few months now, and what I can tell you is there is a noticeable change in the way my muscles re-energize after I use them. What that means is, say I'm involved in some intense activity in the gym or maybe some sporting activity. Normally, the next time I did it, I would be kind of tired. I would be sort of gassed out. That doesn't seem to happen with this. And all I can imagine is because my mitochondrial grid has essentially been upgraded, it's not just my muscles that are getting upgraded, it's all the other cells in my body because they're all powered by mitochondria. Go to timelinenutrition.com/ageist, use the code ageist at checkout, and save 10% off your first order of MitoPure. Today's show is brought to you by Ned's Mellow Magnesium. It's a sleep supplement that I've been taking for about 3 weeks, and it's great. I know a lot of you guys, we have problems sleeping. We wake up in the night or we have trouble getting to sleep, and you should check this out. So it's got 3 different kinds of magnesium. Magnesium is awesome to help us sleep. It's also one of the minerals that 75% of Americans are not getting enough of. Mellow Magnesium also has L-theanine and GABA, both of which are going to help us sleep. And full transparency, Ned shares all of its third-party lab reports right there on its site. So not just the research they do, but the research that everybody else does on their products. And that strikes me as a real vote of confidence from the brand on the products that they do. They have over 5,000 5-star reviews on their products. So I'm not the only one who likes this. You can't become the best version of yourself unless you're getting great sleep. Like nothing else works. You got to get sleep. So this is what you do. Go to HelloNed, that's HELLONED.com/ageist and get 15% off on all their products. Or if you forgot all that, just enter ageist, code ageist at checkout, and you get your 15% off there. Hey, just a quick reminder, stay tuned after my conversation with Afton about pain, and we're going to do, just try this, that little fortune cookie that we put in here to help you live a little healthier, a little longer, and who knows, maybe a little happier. Let's give Afton Hasset a call right now, and we're going to talk about pain. Hey, Afton, how are you?
I'm doing great, David. How are you?
I'm wonderful. Great to have you on. You have a new book called Chronic Pain Reset. And I'd like to learn a little bit about your background and how you came to be interested in pain of all things.
Oh, great. Well, it was not a straight line how I got here. I actually was interested in just becoming a regular psychologist and became interested in pain when I was early in my training. I was working with these women who had depression and other conditions, autoimmune disease, a number of things. And what would happen is whenever we'd make some progress in therapy, their pain would worsen. And it became fascinating. How is this working? We're making progress, or things are getting worse, and your pain is worsening. And so my very smart supervisor, Martha Truax, said, you know what? If you really want to understand this phenomenon, I think you'll like this. Why don't you go to the UCSD library? I was in San Diego at the time, so the University of California, San Diego, go to their medical library and pull some articles on fibromyalgia and chronic low back pain and just read about them. And so this was the olden days. And so I went to the physical library and pulled books off the shelf and read these fascinating medical articles about the interplay between behavior, thoughts, the experience of pain, brain. I mean, it was just such a wonderful, fascinating combination that felt like, wow, you can influence the actual experience of pain by how you think and how you feel. And I was just the possibility that was true got me hooked. And so about 20 years ago, I changed my dissertation and I moved towards the direction of chronic pain. And since then, I've been absolutely blessed to join the team at the University of Michigan. The Chronic Pain and Fatigue Research Center, where I'm a principal investigator at, is one of the premier research sites in the world studying chronic pain. We're within the Department of Anesthesiology at the University of Michigan.
So when I think of anesthesia, I think of drugs, heavy drugs. I guess maybe we should start with, what is pain?
Yeah. Wow. So pain is kind of our warning system. Pain is a good thing. So when we injure ourselves and experience pain, like we put our hand on a hot burner, oh my gosh, we pull our hand back really quickly, which is great, because if we left our hand there on the hot burner, it would be very, very bad, right? And pain, when it happens like a twisted ankle, it tells you, stay off of this. Don't aggravate this. Let yourself heal, retire, regress, sit back. So people who don't have pain receptors often don't live very long, right? They get themselves into all sorts of precarious situations because pain is not there to warn them away from bad things. So a little bit of pain is proper. What happens, though, is pain can change from being something like a stimulus response, meaning that you burn your finger and you experience pain. It can turn into something that's not just pain experienced by burning finger and the brain detects it, to the brain actually creating the experience of pain. So over time, the more you experience a single pain signal, so let's say you have a really bad knee, you got osteoarthritis of the knee, and it's grinding, it's grinding, and it's grinding, it's pain and pain and pain. And 6 months later, your body's been sending this pain signal for 6 months almost continuously. Well, we have an axiom in neuroscience. Neurons that fire together, wire together. So the more we repeatedly experience something, the more likely your central nervous system will remember it and more easily do this. And so the pain coming from that nasty knee becomes almost a natural experience that happens almost on its own. And this is a form of pain that we know as nociplastic pain, meaning that the pain is experienced as a changing in the plasticity of your brain, that your brain has rewired and now is actually either enhancing that pain or making that pain worse. And so that's a very different pain experience than when you have a boo-boo, when you hurt yourself and know you need to stay off of it, than when you have the brain that's actually creating the pain. And that's a type of pain we see very frequently in many chronic pain conditions like fibromyalgia, chronic low back pain, temporomandibular joint disorder, and even like things in the gut, like inflammatory bowel disease, or even irritable bowel syndrome. So even these autoimmune diseases like inflammatory bowel disease, rheumatoid arthritis, and lupus can all create this brain-driven pain.
If I understand this correctly, what you're saying is the stimulus is removed, but the pain signal remains.
Yes. You got it right. You've heard of phantom limb pain.
Yes,
right. You're familiar with that? The concept that where somebody will have a leg amputated or a part of the body amputated, and then they report for sometimes years that limb is on fire, that it still hurts, that it's incredibly painful, but the limb is not there. The representation of limb does remain in the brain. And as long as that representation is in the brain is sending that signal, oh, that limb hurts. And you're like, it's not there. How is my foot hurt? It's not there. Again, it is one of the brain's way that it rewires. It represents parts of our body. And then it can create pain really on its own, or at least amplify pain.
We've had people come on and they talk about the default mode network, how it's the
Yes.
sort of default in the brain that when we're not doing anything else, it just sort of goes to whatever that ancient wiring is. And it's often really helpful to like reset that. Is that part of what we're talking about here?
I'm glad you asked, because it is. So the default mode network is really what's kind of motoring along when we're just kind of thinking self-referential thoughts, when we're kind of thinking about daydreaming and what we can do, and thinking about your body and, what's my back doing? That's just kind of default mode network. What we see in chronic pain is that default mode network is talking way too much to another network called the salience network, which is a network that says, hey, pay attention. This is really something big. Watch out. And so these two networks are over-connected. And so what we look for sometimes in interventions is, does the treatment actually start disentangling these two networks? And that seems to coincide when people say, hey, I'm experiencing less pain. So these two networks are slightly disentangled. So yeah, you're on the mark.
That's a guess. I have no idea.
It was a good guess.
I want to go back to sort of classic pain treatment, which are opioid-based painkillers, which I personally hate. I mean, you'd have to I've had organ removal, I've had all kinds of stuff, and I would rather have pain than the way I feel. I'm just one of those people. But so what is it that opioids do in this whole scheme?
So opioids are wonderful drugs for certain conditions. They are so powerful for surgery, dental surgery, physical, body surgery, an acute accident, you've been squashed in a car accident and you're in terrible pain, cancer pain, phenomenal drugs to treat this really acute driven pain by some sort of injury. And there's almost nothing better, right, to actually give relief. Where the problem tends to come is for conditions like chronic pain, where we think they're predominantly either driven by the brain, or they're driven by inflammation, or some other process. The opioids can be helpful for some people and really not helpful for others. And there really are few good studies that show that opioids are helpful at all for chronic pain. There's some short-term studies that, maybe short-term it can be helpful for, for somebody who is newly diagnosed with chronic pain, maybe it can help initially. But there are no studies about long-term opioid therapy. And so what we've learned over the years, we treat 2,000 patients a year through our clinic, new patients every year coming through our clinic at University of Michigan in our department. And many people come in on opioids, but they come in saying, hey, I've had chronic pain for 8 years. I've been on opioids for 2 years, and my pain is still a 7. If you take me off of opioids, my pain will be 107. And you're like, okay, that could be true, or it might not be true. Because what we do know is that anytime we put something into our body that's not natural, if it is something that our body makes itself, like endorphins or cannabinoids, or dopamine, if you put that in the form of pills and medications, your body just stops making it. It just slows down making it. So it doesn't make its own endorphins to make you happy. It doesn't make its own dopamine so you feel reward and joyful. It doesn't make cannabinoids so you feel peaceful and not nauseous. And that's why when people go off these medications, they have all sorts of side effects. So now the body doesn't know what the heck is going on. It's got to make stuff again, and leads to all the really bad side effects that we see. So what we want people to do when they're on these medications is to see what's going on. Because sometimes one of the things we see when people are on opioids for a long time, their endorphins change. And now they've actually, in many cases, created a situation where the opioids themselves are making the pain worse. It's something we call opioid-induced hyperalgesia. It just means that your pain now is being driven by the fact that you're on opioids. And if we take you off opioids, you'll be shocked in many cases that your pain is better. And so what we really recommend is that if people come in on long-term dose of opioids, we don't know if you're a benefiter because there are some people that do benefit on long-term opioid therapy, or we don't know if you're going to be 1,000,000% better. So the people who we think, have been on long-term opioid therapy, we try to get them to wean off. And we do that with other treatments, other medications, and teaching behavioral things and giving them other things to keep them comfortable. And see what we have. And what we often see is about 4 weeks after being off the medication, patients are like, my pain is better. How is my pain better? I'm off of opioids and I can think well, and my emotions are back, and I'm sleeping better, and everything is better. So, doing this opioid experiment can really be life-changing for some people on long-term opioid therapy if they have chronic pain.
Talk to me about, say, somebody has a common problem. They have a problem with a disc in their back.
Yeah.
Back pain, hurts.
Yeah.
They have trouble sleeping. They can't move around well.
So, when you have something like a disc, let's say you've gone in to see your physician, you say, my back is terribly painful. They send you for an MRI and they show, oh my God, you got a great big bulging disc. And at that point, the decision that the physician makes is, do we send you to surgery and maybe get this thing fixed? And for some people, that's a total miracle, right? They go back in, they fix the disc, and pain is better. For some people, though, they have the big bulging disc, they go in to get the surgery, and then they come out and they're like, my pain is the same. How is that possible? You fix the disc and my pain is the same. This happens with arthroplasty, with people with knees, get a knee replaced, and they come out the other end, they do all the rehab, and they're like, my knee hurts just as bad as it did before the surgery, or my hip. So what is happening again is this nociplastic pain can form in all of these situations. So it could be secondary to the disc, right? So the disc could be driving this nociplastic pain too. So you might have disc hurt and brain pain driven hurt at the same time. But what's even more remarkable is that when we do studies of MRIs to the pain that people report, there's almost never a correlation, meaning that people who have terrible looking x-rays or MRIs of their knees, their back, or their neck often don't report pain. I have horrible knees. I have osteoarthritis of the knees that is beyond belief, and I feel no pain in my knees. I didn't know that because I broke a knee, and my physician, they imaged both of my knees. They said, you have terrible osteoarthritis. How are you getting around? I don't know. But this is something we see all the time. And then other people can have really unbelievable joint pain. They go and get an MRI and the doc's like, I don't see anything. I don't see anything. And so the correlation between what we see on MRIs and what the actual experience is often doesn't match. And we're actually conducting one of the largest studies right now across 14 sites to look at patients who have chronic low back pain, who have been, have reported every kind of way, shape, or form of pain, and then having 2 radiologists read all their back scans. And so we'll be able to say definitively how frequently this happens, this mismatch between the mess in your back and what you feel. Because that person who has that horrible looking back, their pain could be due to A, the disc, or B, due to the brain, or C, due to the brain and the disc. So, and all of these need different treatment. And the bugaboo is, what do you treat? How do you do it?
That's what your book is about. So tell me about this. So tell me, I guess we can just sort of discriminate between sort of 2 kinds of things going on here. So there's an acute pain. I recently had knee surgery. They gave me some oxy. I didn't take it because I hate that stuff. And like some ibuprofen was fine. But they gave that to me just in case. They said, listen, you might have like a pain level of 9. We don't know, but it'll go away. So that would be sort of an acute thing. And then we have someone who has something that we'll say longer than, I don't know, a couple of weeks, something like that. As part of this question, I want to ask you, how long does the pain signal needs to go on for the brain wiring to happen?
Yeah, no, great question. So the chronic pain we consider greater than 3 months, right? So if somebody has a nasty ankle pull and they continue to have severe chronic pain, longer than, or like 3 months, then we say that's not chronic pain. That has kind of crossed the Rubicon, and then we feel a little more confident that now the brain has rewired. But the crazy thing is the brain rewires really fast. So an example I have in my book is a study that was recently published in the last year. And what they did in this study is they wanted to see how fast does the brain rewire. And so they had a group of individuals cast their arm. right? So they put these casts on their arm, and so they could not move their arm at all. And then they did like an fMRI, a neuroimage every day, just about every single day, and watched what the brain was doing. And what they observed is that the part of the brain that processed all the movement in this arm, all those little neurons went dormant. They just stopped working and they were no longer firing because this was now dormant. And so that happened within like a week. So the rewiring happened within a week. But then what was incredible, when they uncasted the arm, the neurons were just kind of like almost like idling. And then the second the arm started moving it, they all popped back into life. And so it just tells us that our brain is so plastic, way more plastic than we ever thought before. So that opens the door that this rewiring of having more pain could happen pretty fast. But then we can also change the wiring also pretty fast by doing different things, by adding different inputs.
So in the cast experiment, neurons go off, take the cast off, and the neurons sort of like, something's going on here. And then they wake up and they go. But which is wonderful. But if we have something that's more locked in, said nerves that wire together, and now they're wired. So now the pain signal is removed, but the wiring is still there. So with that, so now how do you deal with that?
Yeah, we have to kind of sneak up on it. So what we know that's in our purview, things that we could do, there's many things that we do that help change our brain health. Eating well, exercise, sleeping well. That sets the environment for us now to be able to influence because we're kind of dealing with brain health. And that helps with, create new connections when we're eating well, sleeping well, and exercising. Exercise is probably the best thing. And that doesn't mean going to the gym. That means just walking, get outside. all that kind of stimuli is helpful. But the other thing that we have in our little arsenal is that our thoughts and our emotions also greatly impact our feeling of pain. So when we define pain is a sensory, it's an emotional, and it's a cognitive, it's a thought-derived process. Pain exists because there is this awareness of it. So when people are anesthetized, you don't feel pain when they're doing the surgery, right? Once you wake up and you're processing, you're aware, you're emotional, everything's there, you feel the pain. The other piece is that the parts of our brain that process our thoughts and our emotions, the same networks, overlap very well with the pain network. So you might notice that if you've ever injured yourself and you get afraid or really angry, the pain can be worse. Again, it's just a stress response. It's stimulating. It makes the pain worse. If you've ever been in a really fun game playing volleyball with people, maybe you tweak your ankle a little bit, but you just play the rest of the game and you're having a blast. And then at the end of the game, you're like, oh my God, wait a second, I've really hurt my ankle. Again, the positive emotions and distraction keep you away from even really detecting that pain. So our emotions and our thoughts greatly impact the experience of pain.
So my thought here on this, in my experience, my personal experience, it's a two-way thing. So if I feel pain, I get grouchy. I can't think as clearly. It's both, right? So
again, it's all of the networks. And so there was a big kind of belief early on, within 20 years ago, or even recently, that chronic pain is a psychiatric condition because depression and anxiety are so common. It's got to be depression. It's got to be a psychiatric condition. It's not true at all. It really appears more so that pain kind of creates the environment where people become anxious and depressed. And so, it's not that there's this psychiatric condition and one manifestation is pain. It seems to be the other way around. And then we have shown this in a really interesting pair of studies that we did in children. And so it came from a larger NIH effort called ABCD, and it's where they're following a lot of children. And it's funded by NIDA, which is the National Institute that looks at drug abuse. And what they're questioning is that what are the processes that put people at risk for substance abuse down the road? But we also have to ask the question about pain. And so they do ask a lot of questions. And so we have children that are followed over years that not only complete a lot of questionnaires themselves and their parents, but also get neuroimaging every year. And so we can watch the child brain change, right? And so what we determined is, in the first paper, we looked at the children in this database and followed them over time and found that what predicted the onset of pain when they were older adolescents was not depression and anxiety. That didn't set the stage for it. Instead, it was having a lot of sensitivity in the body, being aware of the body, having some cognition problems, because you're just saying how your thoughts get all screwed up, having some cognition problems on the front end, some sleep problems. That's what predicted. And then the thing that was so exciting too is in the neuroimaging. And remember those brain areas we talked about, default mode network, talking to the salience network that we see as a problem in adults with chronic pain, that same dysfunction in children before they had pain. We saw the same level of connectivity before the pain, and they're the children most likely to get pain down the road. So it's almost like the wiring is kind of there waiting.
Wow.
We're looking at this too. So I have a colleague at the Chronic Pain and Fatigue Research Center called Kevin Benke, who does research in psilocybin and cannabis. And so he's kind of our guru of controversial substances. But the thought is the way that psilocybin works, not unlike ketamine, is that by taking it, there is a rewiring. So the wiring kind of gets reset. And that perhaps helping us explain why psilocybin can help with PTSD or ketamine can help with PTSD, because it disturbs some of those circuits. And so we're studying that in pain. I'm more on the outside of those studies. I'm just an observer like all the rest of the scientists. But it's fascinating. Again, it's like, how do we change these networks that are not helpful? And the whole gist of the book is that there are all sorts of things that you can do, these little things that you can do that set the stage for enhancing and changing actually how your brain is processing the experience of pain.
I was having some sort of referential pain, so not actual pain. So they've removed the disc or whatever the surgery is, but I still have this pain feeling because of the wiring. What are the top 5 things you would have?
A great question. You set me up perfectly. So the first question I always ask if I'm seeing a patient is like, how are you sleeping? Right? That is a big one. So if somebody isn't sleeping well, that's our low-hanging fruit. Let's get you sleeping well again, not on drugs. Let's do some behavioral things and get you sleeping. We do so many things to mess up our sleep. That's the first thing we all do. And so, looking at our devices at 10 o'clock at night, that's like giving yourself a blast of sunshine. There's a part of your brain that says, oh, morning. Right? There's so many things we can change. The second thing that I am very interested in is, are you exercising? Are you moving? So what happens very often when people have chronic pain, they get the part fixed, they're already really deconditioned. So their muscles are achy and crampy anyway, and they're now out of the habit of getting any exercise. So get people moving, get a Fitbit, get out there, do an extra 10 steps a day, every day, get out in nature, because the data of how well our brains do and our bodies do, just exposed to nature, even sitting on your patio in front of vegetation, right, is helpful. We need that. We need green space. We need to get out and have the wind in our hair and smell fresh air and get a little sunshine on the face. It's critical. But then I look at stress. So stress is a killer, right? And the brain is very sensitive to threat. And our brain is pretty much wired to watch for threat. That's what we do. We scan the environment. And if something is perceived as stressful, we have a biological reaction to it. And in that biological reaction, we actually make our pain worse too. So I wanted to get people to be better at coping with their stress. And so it's great to teach people some mindful breathing, some ways to think about dialing down stressful thoughts. Many people have thought patterns, rumination, and other things that are not helpful, that make you feel threat. And so we try and do that. And then one of the most powerful things too is distraction. So, finding things that you really enjoy, a hobby you love, something that's totally engaging. So you just get in this state of flow and losing yourself. When you're in that state, you don't feel pain because your attention is in this thing that's very deep. And so the more that we can introduce things that are not pain, the more we start to break those bonds, the more that we introduce positive emotions and get this other part of our brain working, because part of the dysfunction in chronic pain is another part of the brain, the part of our brain that processes reward and pleasure. That tends to get dysregulated too. So many people with chronic pain also have kind of depression. They just feel meh. Nothing is very appealing. They don't want to do anything fun. And that really is because that is a network dysfunction. That's reversible too, by just getting people out and again and connecting with other people and joyful. And again, you just start building this reward up. This is not unlike what we see with people who are off of addictive substances like crystal methamphetamine or some such thing, that part of the brain kind of gets stymied. It stops functioning. So that's the hardest thing, is to get people to start to feel real joy and joy from the body as opposed to joy from the substance.
Is this what's known as pain reprocessing therapy?
Yeah, so that's a little bit in the neighborhood. So pain reprocessing therapy is built on the notion that nociceplastic pain is probably underlying a single person's pain. Okay, the way that we kind of know that it might be a pain that responds to this therapy is if somebody says, hey, I have death-defying pain, just spectacular pain in my neck, but sometimes it's gone. And then I will be driving down the road and it's back and my neck is on fire and I can't breathe and I am afraid to move. And then it'll be there for a few days. I can't move. And then it just subsides. It gets a little bit better, And so people assume it's a disc or some darn thing is driving this. This is probably one of the most clear manifestations of brain-driven pain. When somebody has an injury, the pain doesn't come and go. Right? If you've broken a leg, you kind of know the pain is pretty much there, right? It doesn't come and go. And so pain reprocessing therapy really is built on the notion that now what the brain has done is it at one time was responding to something that was very, very painful. And it was telling you, beware, 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 because that's what pain does. Get your hand off of that hot range, right? Beware, beware, beware. But what happens is the brain can get overprotective. I call it like an overprotective nanny. And it starts just screaming at you when there really isn't nothing that it should be afraid of. So it might get a little twinge and the brain goes, oh my God, quick, jump, move. And so it becomes very, very overreactive. And so pain reprocessing therapy takes this idea and has people who have spoken to their physician. The physician says, I don't see anything on my MRI that tells me that movement is dangerous for you. I want to just start getting some exercise, go to PT, move. And so once people kind of get that, okay, pain reprocessing therapy does not much more than tell you a lot of things I've just told you here, that the brain is the overprotective nanny and is just kind of freaking out. And what we need to do is we really need just to tell the brain that there's nothing here. There's nothing to be afraid of. This is okay. And then what we do is we actually have the person move. And so if the person has a neck they haven't moved in 3 years, we'll tell them, talk to your brain to say, it's all right. I know there's no problem, and just start moving. And usually about a minute into it, the person is moving and crying because now it is gone. So not everybody has this pain. We don't even have a good guess how frequent it is. But for the people that have this type of pain, this is like a miracle. Pain isn't totally gone. It shows up and sometimes it goes to different parts of the body, but the person now knows what's happening and can kind of do this, whatever this is. Because again, it's just the brain saying, watch out. Start with your physician, number one, because you want to make sure that it isn't some form of damage, that you don't have, God forbid, a tumor, or you have something that really needs to be addressed. Pain is there for a reason. It's there to warn you. So pain does a job. So find out what it is. But if it's the type of pain that you've had for years and that the physicians say, hey, you really should be moving, I don't really see anything here that, and has been reassured that, get into physical therapy, get moving, then you can think, this may be the type of chronic pain that I can do more with. Right. And so that at that point, you want to have ideally a physician that's helping you, perhaps a physical therapist is helping you, but also doing pain, doing your pain self-management. And that's really what the book is kind of all about. It's not just the pieces that you can do to make your pain better. It really is about the pieces you can do to make your life way better. I come from the school of positive psychology. I think about, traditional psychology. I also think about resilient psychology. And how is it that we not only teach people the skills that they need to lessen their pain, to sleep better, to have better relationships, but to actually have a life that is really rich, because the people who are the most resilient are the ones that actually have some adversity in their life and get past the adversity and actually grow and learn from it. And it's a big kind of theme in the book is, getting yourself to the next level. We all had bad things happen. The question is, do we step back and say, wow, that bad thing actually led me to this thing, which is amazing. And so the book really focuses on, really, you can get out of it what you put into it. So you can learn a few great skills, put them into work in your life, maybe get yourself moving better. Maybe you can do some, corrective actions on your sleep, or you really can maybe revisit your life and kind of think about what really matters and how to lead a life that's more intentional and more grounding and richer. And I know we talk a lot about aging, but how do we age successfully? How do we apply these principles? Because so many of the principles in this book, yes, the whole book really pertains to chronic pain, but many of the activities, skills, and practices that people learn in the second part of the book are appropriate to all human beings, because we all do strange things with our emotions. We all think thoughts often that are not helpful. We sometimes defeat ourselves with all sorts of, of behaviors. And then, and we often don't prioritize what's really important in life so we can lead a long, healthy life. So,
like so many things in life, we don't always have to accept the grim reality.
We can make our own reality, right?
Exactly. Yeah. Very good. Afton, it's been wonderful having you on.
Well, thank you. You asked such great questions. You probably got a whole neuroscience lesson that you weren't ready to have, but hopefully pieces will stay with you and your audience and will be helpful.
Enjoyed having you today.
Thank you very much.
Quick reminder, Afton Hasset's book is called Chronic Pain Reset, and it's filled with lots of exercises to help us retrain our brains if we're in chronic pain and we want to do something about it. So a really great book. It was great having Afton on the show. After we had this conversation, I brought this up with my PT, Ryan, here in Park City. And I said, this idea that chronic pain can go on even after the physiological stimulus has been removed, the brain still can feel pain. And he told me this really disturbing story about how they have a number of young girls, sort of young teenage girls, who will come in with a perceived issue with a joint, a knee, an ankle, something like that, and saying like they can't play sports, and they'll check it all out, and there's like no real damage there, and people can't quite figure out what's going on, and they have to prove to the girl that she's actually okay by having her do exercises to show that the knee is actually solid, or the ankle, whatever it may be. And he told me really tragically, like if they'll have girls who will come in on crutches, who've been on crutches for like 4 years, or in a wheelchair because they think something's wrong. And it may have originally started as a way for them to get out of, maybe they don't like to do sports. So they're like, I can't do sports because my knee hurts. But then it continues, and it can be life altering unless something is done about it. So that was really eye-opening. Anyway, we're going to get with Just Try This after a quick word from one of our sponsors. Today's show is also brought to you by Inside Tracker, the dashboard to your inner health. I'm a big believer in getting blood tests taken because it's simply the only way to get in-depth data about your metabolic factors, your hormones, and the things that inform your immediate and long-term health. There are also excellent DNA tests that can further inform you about your immediate and long-term health. The problem is the most blood tests out there is you get a lot of information back and you get a lot of numbers, and they're not really going to tell you what to do about it. In addition, they can be very confusing, what all the factors are, what they mean. Inside Tracker has a dashboard and a platform that simplifies all of that. I get food first, supplements second recommendations about how to optimize my inner health. For instance, I just got my test back and I saw that my calcium levels were a little low, which were surprising to me. But I have suggestions now about how to correct that. And I would not have known that had I not done an Inside Tracker blood test. Go to insidetracker.com/ageist. Save 20% on all their products today. This week on Just Try This, it's a bit of a reminder. You guys all know this. I'm just going to bring it up. Sunblock, mineral-based sunblock. Did you know for every 1,000 feet in elevation you go up, the intensity of the UV goes up 5%? So for instance, I live close to 7,000 feet. So the sun here is 35% more intense. The UV radiation is 35% more intense. And if there's snow out there and it's reflecting off the snow, it's like being in a microwave. Very, very tough on your skin. So just try and remember to put some mineral-based sunblock on. I use some like tinted stuff. I think I actually look better with the sunblock on than with it off. I know some of the ones that are like pure white, it can be a little weird. And also, depending on the tone of your skin, you want something that matches with that. As any dermatologist will tell you, UV is not a friend of your skin. And especially if you start going up in altitude, it can be even more. So this week on Just Try This, try and just remember to put some mineral-based sunblock on before you leave the house in the morning. Even when it's cloudy out, the UV is going to go through those clouds. So just try this. Wear some sunblock. Thanks, everyone, for joining us on the show today. I so appreciate your time and your attention and the thoughtful comments that you send in. If you have anything that you would like me to pass on to Afton or any questions for me, David at SuperAge.com. I'll answer all my email promptly and personally. And every week I ask for your help. And here it is. Here's my pitch for your help. Leave us a comment. Please forward this podcast to a friend to say, hey, this is sort of interesting. You might like this. And hit that subscribe button. This is really the only way we grow. It's the only way we can reach more people. We don't spend a lot of money on advertising. We spend zero money on advertising. The only way that you guys know about this is probably somebody told you about it. So maybe pass it on. Until next week, everyone, have a wonderful week. It's great to be alive. It's great to have you with us. Take care now. Bye.